Hi, everyone. I'm Dr. Shen, one of the glaucoma specialists at Massachusetts Eye and Ear. And in this lecture, I will be talking about measurement of intraocular pressure. Here's an outline of the talk. We're going to start with why we measure IOP for glaucoma. Then I'm going to cover aqueous humor dynamics, including aqueous production and aqueous outflow. We will discuss how to measure IOP, what influences IOP. I will discuss briefly the ocular hypertension treatment study and end the session with target IOP. So why do we measure intraocular pressure? The definition of glaucoma is that it is a chronic progressive optic neuropathy for which elevated intraocular pressure is an identifiable risk factor. It is often insidious in onset. It has no symptoms until the disease is advanced, and unfortunately, it causes irreversible vision loss. Hence, IOP being an identifiable risk factor is important for us to know when it comes to assessing for glaucoma. Why is IOP important? Visual acuity and IOP are the vital signs for glaucoma. In fact, it's so important that the American Glaucoma Society decided to use it as their symbol. Currently, lowering IOP is the only way to treat glaucoma. And in patients with glaucoma, the pressure needs to be lowered further to prevent damage to the optic nerve. How does glaucoma happen? This is a very simplistic view of the eye. I'm just going to briefly touch up on aqueous humor dynamics here, and we're going to elaborate on this further. So first of all, the fluid of the eye or the aqueous humor is made by the ciliary processes behind the iris. Aqueous humor travels through the pupil and is drained in the structure known as the angle. And if the angle does not drain properly, pressure can build up in the eye, causing damage to the optic nerve and leading to visual field loss. Now let's look a little bit more in detail at aqueous humor dynamics. Aqueous humor is made by the inner non-pigmented ciliary body epithelium at a rate of 2 microliters per minute. And keep in mind that the anterior chamber volume is 250 microliters. The juxtacanalicular trabecular meshwork represents the greatest resistance to aqueous flow. So before we go on, I want you to think about this board question, which is, which of the following has the highest ratio of aqueous to serum concentration? So in other words, which of the following is higher in aqueous than it is in the serum? And your options are A, protein, B, calcium, C, phosphorus, D, ascorbic acid, and E, sodium. And I just hope that you spend a second or a minute to think about it before looking at the answers. And the answer is choice D, ascorbic acid. Aqueous humor is very low in protein. In fact, if you see protein, that's when you notice the flare in aqueous humor on the slit lamp exam. Aqueous humor is low in calcium and phosphorus and has similar concentration of sodium to plasma. So the site of blood aqueous barrier is at the location of the non-pigmented ciliary epithelium and the pigmented ciliary epithelium. What you can think about this is like a sandwich with 2 basement membranes on each side, and you see the epithelial cells against each other. So the ciliary body stroma is where aqueous starts to form, travels through the pigmented epithelium, the non-pigmented epithelium, and then travels into the posterior chamber. And another way to think about it is that the different parts of the retina is contiguous with different parts of the ciliary processes. So the pigmented layer of the retina is contiguous with the pigmented epithelium, and the neuroretinal layer is contiguous with the non-pigmented ciliary epithelium. The production of aqueous humor. There are multiple mechanisms. including active secretion, which is IOP independent. It is made by the double-layered ciliary epithelium, which I just showed you, and involves carbonic anhydrase too. And in fact, this is the most common form of aqueous production and makes the most aqueous. Ultrafiltration is a pressure-dependent fluid movement, and the pressure gradient is between the capillary pressure in the ciliary body and IOP. And there's also simple diffusion of passive movement of ions. Aqueous humor production decreases with age, trauma, inflammation, systemic medications such as beta blockers, and carotid occlusive disease. There are multiple treatments that target aqueous humor production. This includes carbonic anhydrase inhibitors. Remember earlier I said that active secretion is the most common mechanism, and that involves carbonic anhydrase. So the inhibitors such as dorzolamide and brinzolamide lowers aqueous production. Beta blockers also lowers aqueous production, alpha agonists, and now the new rho kinase inhibitor. Also, we have lasers which treat the ciliary processes and make them less capable of making aqueous, such as endoscopic or transscleral, diode, or micropulse cyclophotocoagulation. Now remember, when we're talking about intraocular pressure, we want to look at the Goldman equation, which pressure or IOP is equal to formation of aqueous, which is at about 2.5 microliter per minute, divided by the facility outflow, which as you can see over here, plus the episcleral venous pressure. So the total facility, which is the term here as C, is both the trabecular meshwork outflow and the uveoscleral outflow. And just keep that in mind. And as you may know, prostaglandin analogs enhances uveoscleral outflow. I want to look a little bit further at trabecular meshwork outflow, which if you were to enlarge it, you can see that there's again aqueous humor, which is made in the posterior chamber, travels through the pupil to the anterior chamber and drains through the trabecular meshwork, which has 3 layers, with the juxtacanalicular layer being the site of resistance. So here we have aqueous humor traveling through the juxtacanalicular tissue within trabecular meshwork, then drains into Schlemm's canal, collector channel, aqueous veins, and episcleral veins, and outside the eye. And on the microscopic level, you can see that the trabecular meshwork consists of beams and sheets of extracellular matrix material lined by these specialized trabecular endothelial cells. And fluid drains from the anterior chamber to Schlemm's canal. So here you see the anterior chamber, there's a trabecular meshwork, and here's Schlemm's canal, and then subsequently to the episcleral veins. The endothelial cells and the formation of these giant vacuoles, which you can see one here, contribute to the fluid flow. The uveoscleral outflow is also another pathway for aqueous to get out of the eye. This is pressure independent, where the fluid travels from the anterior chamber to the ciliary muscles to the supraciliary and suprachoroidal space, as you can see here, down here. So here's another board question. Which of the following is true regarding uveoscleral outflow? Choice A, it is possibly associated with IOP. Choice B, it is not affected by glaucoma medications. Choice C, atropine increases uveoscleral outflow. Choice D, it allows for passage of aqueous humor into episcleral veins. And choice E, cyclodialysis causes a decrease in uveoscleral outflow. And again, think for a moment to yourself. And the right answer is choice C, atropine increases uveoscleral outflow. Because it is IOP independent, it is affected by glaucoma medications such as prostaglandin analogs, It actually does not drain to the episcleral veins, but gets to the suprachoroidal space. And cyclodialysis cleft actually causes an increase, not a decrease in uveoscleral outflow. And on the contrary, which of the glaucoma medication decreases uveoscleral outflow? And the answer there is pilocarpine or miotics. So again, going back to the equation, which we already looked at, this is the Goldman equation. Remember, episcleral venous pressure is the extra term here. And there are certain conditions such as Sturge-Weber, thyroid disease, and AV fistula, which can increase episcleral venous pressure. And here you see an example with the veins very much engorged. And this is probably a situation of AV fistula. Now, moving on to aqueous measurement. This is not IOP measurement, but aqueous measurement. A lot of these are not actually used clinically, such as manometry, where you actually stick a needle into the anterior chamber, and obviously that's very invasive. This measures IOP. Tonometry, which is the most common one, and I will be discussing that further. Tonography measures the facility of outflow, and flow photometry measures aqueous production, and these are more performed in laboratory settings. How do we measure IOP? Manometry is the most accurate, but also it's invasive. And here's examples, or here are the options for tonometry, which help us to measure IOP, such as non-contact or air puff tonometry, indentation, applanation, hybrid applanation, and indentation, which is commonly used in the tonal pen, contour molding, which is a Pascal, and the rebound tonometry, such as the use of eye care. Keep in mind that the ideal way to check IOP is dependent on the scenario. For patients who had a transplant of the cornea, pneumotonometry may be best suited for that. For patients who had LASIK surgery, dynamic contour tonometry or Pascal tonometry is the best. For patient who has a artificial cornea as a corneal keratoprosthesis, finger tension probably is employed because the cornea is rigid. If there's no anesthetic available, rebound tonometry with eye care is often performed. And for a patient who's supine, such as in the case of examination under general anesthesia, the Perkins can be used, and sometimes the Shields can be used as well. Now, the Goldman applanation tonometry is probably the most commonly used tonometry clinically. The way we perform the applanation is that we numb the eye with some drops with the fluorescein dye already placed. And then the applanator tip, which has been sterilized before, barely touches the eye. It takes a few seconds and is performed at every clinical visit. And as you can see in this image, this is what you're supposed to see. You're supposed to see the two Myers meet in the middle, and you want to see the Myers being thin and not too thick. And this helps you to get an accurate measurement. To achieve this, first you want to again make sure that the tip is sterile and it flattens the constant part of the cornea. Make sure the tip is dried so that you don't cause a corneal abrasion. You tell the patient to look straight ahead, and also importantly, tell the patient to continue to breathe so that you don't get an artificially higher IOP. I want to show you some examples of what the Myers could look like, as in this is what you should be seeing. And if you see this, you know that the actual IOP is higher. If you see this, you know the actual IOP is lower. If you see this, you know that there's too much dye and you can't measure it accurately. So you should really wipe the patient's eye and wipe your applanator tip. And if you see this, looks like that the dye has been there too long and have been drained too much through the patient tear duct system, and you have to apply a little bit more dye to get a more accurate measurement. If you see this, which is half circles, that actually means the patient has a contact lens on. And I would suggest that you should always examine the eye before you put the dye in, or in this case, if you notice after the fact, remove the contact lens and check pressure again. if you see this, that means that the patient has certain amount of corneal astigmatism. And if that's the case, you want to measure it horizontally and then rotate the applanator tip 90 degrees to check pressure again, and then take the average for the IOP for the eye. So remember, for Goldmann tonometry, we're varying the force and we're fixing the area of the applanator tip. And this is based on the Fick principle, where pressure equals force over area. And the area is basically based on a 3.06 millimeter diameter of the tonometer tip. And the reason for the size is because at 3.06 millimeter, the surface tension of tears offsets the elective forces of the cornea. Of course, this is assuming that the cornea is a perfect sphere and it has the normal elasticity properties. Here is another question for you. And again, I highly encourage you to think about these questions rather than just go straight to the answer, because this is probably the best way to help you to learn. Which of the following statements about tonometers is false? A, the Schia's tonometer indents the cornea, resulting in substantial increases in IOP during measurements. B, the Pascal contour tonometer is a form of applanation tonometer that yields measurements of IOP that is most insensitive to central corneal thickness. C, newer version of non-contact tonometry use only the necessary bolus of air to flatten or upplane the cornea. And D, there is no nomogram that accurately converts Goldmann applanation tonometry readings to true measures of IOP. And remember, we're asking for the false statement here. And the correct answer is B, as in this is the false statement, because the Pascal contour tonometry is a form of contour tonometry and it's non-applanation contact tonometry, which is independent of corneal biomechanics properties and thickness. And so it is not an applanation tonometry. Now that you know how to measure pressure, let's see how IOP distributes in the population. So you may know that the mean IOP is around 15.5 millimeters of mercury, and the standard deviation is 2.6 millimeters of mercury. However, as you can see in this graph here, the distribution is non-Gaussian and is skewed toward higher IOP. 21 millimeters is greater than 2 standard deviation above mean IOP, and that's why 21 has been considered the cutoff value. So moving on to this question, true or false, glaucomatous damage only happens or is only caused by IOP above 21 millimeters of mercury? And the answer is this is incorrect. And the reason is that there's multiple mechanisms of glaucoma. As you can see here in this diagram, this plots IOP over here and the population distribution here. And you can see that there, and here's the 21 cutoff, there are patients who have higher pressures above 21, but have no visual field loss and hence no glaucoma. These are known as the ocular hypertensives. And on the contrary, there are patients who have visual field loss and glaucoma at pressure under 21. These are known as normal tension glaucoma patients. So therefore, the relationship between IOP and glaucoma is not as straightforward as with the cutoff of 21. The percent of normal tension glaucoma cases in surveys of open angle glaucoma, it is found that 11 out of 15 glaucoma surveys, in 11 out of 15 glaucoma surveys, that more than 50% of open angle glaucoma cases could be labeled NTG. And in the Japanese study, more than 90% of OHG patients could be labeled as NTG or normal tension glaucoma. And a little bit more about epidemiology of IOP. You can see that in the US study, the mean IOP is about 15.3. And similarly for some of the European population, however, in Africa, the mean IOP is higher, but it is lower in the Japanese population. So the IOP for the mean is different for different patient populations. And the Baltimore Eye Survey, it was found that higher pressure definitely increased the risk of POAG, as you can see here, especially with the pressure much, even under 21 can increase the risk of POAG. So the consensus is that there's a strong positive relationship between IOP and open-angle glaucoma, although open-angle glaucoma can occur across the entire spectrum of IOP. And I think that's really important. So I'm going to just show you that slide again so that you can review it. Okay, what can affect IOP measurements? One of these factors is central corneal thickness, or CCT, and normal thickness is about 550 microns. And this table is not meant for you to memorize or correct IOP, but only to know that the thinner the cornea, the lower is the measured pressure and the actual IOP is higher, and vice versa. The thicker the cornea, the higher the IOP, but the actual pressure is lower. Furthermore, patients with thinner cornea are at higher risk for glaucoma. And as you may know, more recently, some of the hysteresis data showed that glaucoma patients also have more rigid corneas. So central corneal thickness, or CCT, averages between 520 to 580. It is highly heritable, and as I mentioned earlier, the material property is probably more important than CCT in terms of impacting both the IOP measurement and also probably risk for glaucoma. In terms of thickness, African Americans tend to have much thinner cornea than Caucasians, and lower CCT is a risk factor for converting from ocular hypertension to POAG. However, sometimes the adjustment does not improve accuracy of applanation reading, and hence corneal thickness should only help us to interpret IOP, but not meant to correct the IOP measurements. Other factors that can either lower or increase IOP or decrease IOP, for the ones that could increase it, include those that can increase episcleral venous pressure, such as Valsalva, breath holding, and tight collar, if the patient is squeezing their lid, and extraocular diseases such as thyroid eye disease or even caffeine intake can increase IOP. Medications such as steroids can certainly increase IOP. For factors that can lower IOP include exercise, anesthetics such as succinylcholine, pregnancy, alcohol, marijuana. As you know, a lot of patients have been asking about the use of marijuana for IOP lowering. At this point, we have not found this to be a consistently lowering methodology that is safer than the glaucoma medications, and hence the American Glaucoma Society is not recommending prescription of CBD for glaucoma. Also keep in mind there is diurnal variation of IOP. Subjects without glaucoma, the diurnal variation is somewhere between 2 to 6 millimeters of mercury over the day. The peak daytime pressure is in the morning hours in most people, and higher IOP with greater than 10 millimeters of pressure fluctuation is suggestive of glaucoma. Other potential factors associated with IOP include age, and there is evidence for IOP and age, but it's contradictory based on whichever study you're looking at, so it's unclear. And also for gender is also a bit controversial or contradictory from some of the population studies. However, for diabetes and IOP, there's a strong consensus that patients with diabetes tend to have higher IOP than patients without diabetes. Now let me move on to talk about the ocular hypertension treatment study. The purpose of the study is to evaluate efficacy of treatment in preventing visual field loss in glaucoma patients with visual field loss from glaucoma in patients with ocular hypertension. So in other words, do we treat the patients whose pressure is above 21 when they don't have glaucoma? They enrolled over 1,600 patients with ocular hypertension in the 1990s, and they randomized them to either observation versus treatment with medical therapy. And pressure was lowered by on average 22.5% in the treatment group. And over the 5-year period, the risk for developing primary open-angle glaucoma was reduced from 9.5% in the control patients to 4.4% in the treated patients. They found that ocular hypertension patients tend to have thicker central corneal thickness than general population, and the risk factors for converting from ocular hypertension to POAG included older age, higher IOP, thinner CCT, larger cup-to-disc ratio of the optic nerve, and higher pattern standard deviation on the baseline visual field. And here is a diagram showing you the risks of, again, converting from ocular hypertension to POAG. And you can see those with the highest risk have the highest pressure and the thinnest CCT. So both of these, IOP and CCT, are contributory. Here is another question. In the ocular hypertension treatment study, patients with ocular hypertension were randomized to medical therapy or observation. Which of the following statements is or are true? And again, I encourage you to think about it before you look at the answers. So choice A, the IOP lowering target of 20% was achieved in almost all patients with a single medication at 5-year follow-up. Choice B, the conversion rate to glaucoma was identical in the two groups. Choice C, the most common finding among patients who converted to glaucoma was an optic nerve hemorrhage. Choice D, IOP lowering in the treated group was approximately 22.5%. And choice E, repeat visual field testing failed to confirm the majority of visual field abnormalities in reliable but abnormal visual fields. So think about it. The correct answers are both choice D and E. And just to go over these, as it turned out, 50% of the patients in the treatment arm required at least 2 medications to achieve the 20% lowering from target IOP. And the conversion rate to glaucoma was not identical. It was less in the treatment group, which was about 4% versus 9% in the observation group. The most common finding was thinner CCT, which is found to be a risk factor for glaucoma. IOP lowering the treatment group was approximately 22.5%, which is correct. And repeat visual field testing failed to confirm over 85% of the visual field abnormalities in these reliable but abnormal visual fields. So this really kind of highlights the difficulties sometimes with visual field testing. Here's another question related to the ocular hypertension study. This is a 48-year-old Black female with ocular hypertension. She has a family history of glaucoma. Her IOP was 24 millimeters of mercury in both eyes. Her CCT was 520 microns, cup-to-disc ratio of 0.4 in each eye, and you see the pictures here. And the PSD was 1.53 in the right eye and 1.76 in the left eye. Now, the question goes, based on data from ocular hypertension treatment study, which of the following is or are true about this patient? Please remember that the question is asking you based on this particular study. And I think that's really important. So choice A, having a positive family history of glaucoma increases the risk of converting to POAG. Choice B, being of African descent increases the risk of converting to POAG. Choice C, having a CCT less than 550 microns increases the risk to converting to POAG. And choice D, all of the above are true. Again, I want to give you a moment to think about the right answer. And the answer here is choice C, having a CCT less than 550 micron increase the risk of converting to POAG because the other risk factors were not identified in the ocular hypertension treatment study. Now, moving on to the last topic, which is establishing a target intraocular pressure. The definition of a target IOP is the IOP that in the estimation of the treating physician will prevent a patient from losing functional sight from glaucoma in their lifetime. And what I want to emphasize is that this is a work in progress. You may not know the target IOP the first time when you see a patient, and it will take time for you to decide and modify the target IOP. So it's not like once you have established the target IOP that is written in stone. Factors that you want to consider for target IOP include the magnitude of damaging IOP. In other words, at what pressure were they getting worse? Central corneal thickness, the degree of pre-existing damage or the stage of disease. In other words, patients with mild glaucoma probably don't need as low pressure for target compared to patients who have severe glaucoma. The suspected lifespan of the patient. So is this a healthy 70-year-old versus a bed-bound 90-year-old? And so to illustrate this, I'm going to show you an example. This is a typical question that I often walk into. A patient tells me, technician just checked my pressure, it's 15, it's good enough. Now remember that IOP is only one piece of the puzzle. Another piece is the corneal thickness. In this patient, the CCT is 450 microns, so the adjusted pressure would be higher. You don't necessarily need to know the number, but just to say that it's actually much higher than 15. Another piece of the puzzle is how is the optic nerve looking like, and this patient's eye has cup to tear ratio of 0.9 and OCT showed very thin nerve fiber layer, and the visual field loss showed that there is a defect encroaching the inferior central vision or encroaching inferior fixation. And here are the actual images, the optic nerve you see here, the RNFL, which shows thinning in both the superior and inferior post, and visual field with most of the inferior visual field already being quite affected. So the way I think about target IOP is that this is a patient with advanced glaucoma, thin CCT. He happened to be a 65-year-old, otherwise healthy male. And so the goal IOP should be much lower. So I would like the goal to be around pressure of 10. So again, just to remind you, the way we use IOP, target IOP, is to record it in a range rather than just a number, so that if you say target pressure is 15 and the patient comes in with a pressure of 16, that could be tricky. Like, do you adjust medications? Do you watch the patient? So usually I would say, is it high teen, mid teen, low teen, or under 10? Target IOP should be reevaluated at every visit, and based on progression or lack of progression, you may decide to either lower the IOP if there's progression at your target IOP, or to raise the IOP if you've observed the patient above the target for several visits and the patient has not shown progression. So this is, again, to remind you, this is how we use it. So in summary, IOP is considered a vital sign for glaucoma. It is determined by a combination of aqueous production and aqueous outflow. Various corneal conditions require different ways to check IOP, and having an elevated pressure does not mean that the patient has glaucoma. And unfortunately, currently lowering IOP is the only way to treat glaucoma. Thank you for your attention, and I look forward to seeing you for the live session.